people filtering in from the back, but while everybody loiters in, I'm going to go ahead and get started. Jordan's got the camera out. That doesn't make me nervous at all. Welcome, everybody, to the Georgia State School of Public Health Grand Rounds. This is the third year of us doing this series, and I just am really pleased as the chair of the Grand Rounds Committee to continue to see the caliber of speakers that have chosen to join us, and Dr. Dean is no exception. So Dr. Dean is an associate professor in epidemiology at Johns Hopkins in the School of Public Health. In her work as a social epidemiologist, her work focuses on privilege and health, including social and economic determinants and disparities in chronic disease. She has quite the CV, as our students learned earlier today, including funding from NIH and multiple mechanisms, the Robert Wood Johnson Foundation, Center for AIDS Research, and institutional grants. As one of the students told me after her talk today, she's done basically everything there is to do and is highly impressive, including participating in the Fulbright program and other very admirable fellowships throughout her career. So we are just so pleased to have you. I like to keep these introductions short because I think we want to hear from you and not from me. So welcome. And before you get started, I just wanted to offer you a thank you before I get off the podium for coming to GSU. And we're so glad to have you, Dr. Lorraine T. Thank you. Thank you.
Thanks for that introduction, Jelaine. So, in the U.S., we know that income inequality has risen nearly unchecked. And we also know that federal minimum wage has not kept up with inflation, and as well as a rising epidemic of housing challenges, especially in the rental housing market. What that reminds us is that things like income and poverty are not necessarily a result of personal decisions necessarily, or a desire or a lack of personal earnings, but that, as Mayor Libby Schaaf would say, poverty is a policy failure, not a personal failure. Oh, thank you. Mayor Libby Schaaf said that. I didn't say that, just want to be clear. But thanks so much for having me. I'm Lorraine Dean. I'm Associate Professor of Epidemiology, Oncology, and Health Policy and Management at Johns Hopkins, as Jelaine said. And I'm excited to be here today and to share the stage actually with some folks before me who I even trained with. So we talked about Dr. Hani Stoklosa, who I went to undergrad with, and Dr. Dustin Duncan, who was here earlier this year, one of my closest friends from graduate school. So I'm excited to be here and occupy this space and to tell you a little bit today about some of the work that's going on across the nation in the topic of guaranteed income and health. So I'm a social epidemiologist, so I am in an epidemiology department, but part of my goal is to think about how do we reframe the causes of disease distribution as things that are social, as opposed to things that are biological. But that also leads us to think differently about the types of interventions that we do, and that the interventions that we do might be along the lines of social and policy change. And that's exactly where guaranteed income fits into health here. So today I'm going to walk you through a little bit about how guaranteed income works, what it is in the U.S. context, because the U.S. context is unique from many other contexts, especially in a high-income country. It's different than what we see in some of the low and middle-income contexts. And then I'll share some preliminary findings from a series of studies that we've been working on to better understand the links between guaranteed income and health. So first, let's start with basic. What is guaranteed income? So I imagine, by show of hands, have you heard of basic income? How many people have heard of it? Okay. Keep your hand up if you've heard of guaranteed income. Okay, so some of the hands went down. And actually, that's because they are a little bit different, and we'll talk about some of the ways in which those things are different. But the basic principle is the same. So the idea is that you're receiving some sort of, it's a cash transfer program, but particularly it's continuous. That means you receive it over time and it's recurrent, not just one time. It's unconditional. So that means that other than some very, very basic administrative questions to see if you are eligible, you don't lose it for some reason. Once you get it, you get it. There are no conditions, no strings attached. And it's also unrestricted. Unlike some other safety net programs which require you to use them on certain products or services, you can use it however you want. It preserves your autonomy. So there also tend to be very minimal or no eligibility requirements, and it may or may not meet your basic needs. That's one key difference that we already see between this and basic income. that this is an income supplement amount that may or may not actually be enough to meet your basic needs. It's just a little bit of extra help. It also differs from other safety net programs that we have in the United States by being a steady, predictable stream of cash to spend how they see fit. So as I mentioned before, it's not quite the same as universal basic income. And you can see from this graph that there are some similarities and some differences. So some of the similarities that you'll see, for example, is it is a cash transfer program, right? It's not vouchers, it's not in kind. It is a cash transfer program. So it's along the spectrum of cash transfers. I pushed the wrong button. There we go. It's along the spectrum of cash transfers. Oh, this was working before, but it's not. Will this work? Can you see it if I do it on here? No. All right. So it's along the spectrum of cash transfer programs, but in terms of conditionality, you see that it's unconditional, as is universal basic income. But the difference on the y-axis is that it is not intended, it's not targeted in the same way. So you see universal basic income has the word universal in it. So it's also not intended to be for everyone. Universal indicating for everyone in a population. In this case, guaranteed income, which you see up in the top left quadrant, is intended to be needs-based. And that makes it a bit different than basic income, right? This is something that's targeted to people who need it instead of being for everyone, an income supplement for everyone in a society. We'll come back to why that's important. But first, I want to talk a little bit about some of the opportunities and critiques that you might hear about a program like this, given those characteristics. Well, some of the great things about this is that it gives people autonomy, right? People can, for example, take the income supplement and they can wait. They can either change their job or maybe wait for a better job to come that fits their needs, right? So it gives people a little bit more flexibility in terms of what they do and how they meet their needs for their family. They can even, for example, choose to school or to go to school or to stay home to care for a relative. And it also is considered something that may eliminate kind of the trap of poverty, because it gives people an opportunity to get resources that they need in the ways that they need it so that they can make this sustainable in the long term. Also, it's considered something that's simple and straightforward. So it's supposed to be designed as something easy to execute and low administrative burden. So again, not a lot of conditions, not having to check if someone's continuing to be eligible. Once you start getting the money, the work is just getting you the money every single month. No strings attached, no questions asked. So in that way, it also costs less to administer than some of the other programs where someone has to have a recurring eligibility and has to be able to prove that. That's time burden both on the recipient as well as on the system that has to now determine whether or not the person is continuing to be eligible. When it's targeted by age, they've also seen some things like young couples, for example. They'd have more money to be able to start their families. They've seen this in countries with low birth rates, has been really, really important so that young people, young families can start their lives on shore footing. And it can also help stabilize the economy during recessionary periods. So I think we talk about how people had stimmy, right? We had the COVID stimulus, which might be similar to basic income. We'll come back to that in a quiz in just a couple of minutes. But so it could help stabilize people so that because they know that there is support for them even when there are recessionary periods. Now, you've also probably heard some of the critiques, right? People say, well, this is something that's going to trigger inflation. If you start giving people more money, it'll increase the demands for goods and services. So there are a couple of responses to that. One is that is one way in which guaranteed income and basic income are different, right? We're not giving money to everyone. We're essentially working to bring the bottom up, right? So it might not trigger inflation in the same way that giving money to everyone would, because we're actually dealing with the problems of absolute poverty and thinking differently about relative poverty, right? I'd also say that there are many different things that also trigger inflation. And we have policy tools, things we just saw one come out recently, right, the Inflation Reduction Act, to help combat inflation. So I don't think that's a good enough reason to say that these programs, we shouldn't do them. We also, similarly, people say the same thing about the standard of living increases may decline because prices will be inflated. We kind of just talked about that. But some of the other critiques are really rooted in, I would say, either a lack of evidence or potentially disingenuous arguments. And I want to bring them up because I want to make sure that you're equipped when you hear these arguments to talk about them in a productive way. So for example, some people say, these small amount of payments, a small amount of money won't make a real difference to poverty-stricken families. I don't know if you've ever experienced time in poverty or spoken with poverty-stricken families, but every little bit really does help. And the way that they have often learned how to stretch a dollar is incredible. And when we would argue that actually even small amounts of money is going to be more helpful for poverty-stricken families than anyone else, right? Even that little bit. Getting an extra $1,000 when you were making $7,000 on average a year is much, much different than someone who is making $50,000 or $60,000 and getting an extra $1,000. So it actually might mean more, even if it's a small amount, to someone who's living in poverty. There's also, some people also say that, getting more money will disincentivize employment, right? People will stop working. Why are we paying people to just sit around and sit home? Well, we actually haven't seen in these programs, and there have been these programs for over 50 years, we've actually seen that that is not true. That just doesn't bear out. When you control for changes in the labor market, just natural fluctuations in the labor department, it actually doesn't disincentivize people to work. They actually have not seen those detriments on the workforce. And in fact, in the individual cases that they've looked at where people did stop working, it was often going from working 3 jobs to 2 jobs, or 2 jobs to 1 job, so that they could do and spend that time either investing in themselves or investing in their families. But by and large, that has just not borne out in the evidence that we've seen. People also say, I don't want this to be a handout. We don't give people handouts. I had to work for what I got, right? Everyone else should. But people talk about this as a handout, but it's really not a handout. I would say, a hand up. And I would say it's a hand up in a couple of ways. One, it's not enough to meet someone's basic needs. So it's literally just some help for them to get to the next step, right? They still have to be able to do something with it. And by and large, they will still have to work and contribute to society in whatever other way they do that may or may not be work. That might be caretaking, that might be doing other things. But these people are still offering a value to society. So we don't want to talk about this as something that's a handout. It's help. It's supplemental help. And we help people in many other ways that we don't refer to and talk about as a handout. So when you hear about this, and I think especially because it's cash, people really have a hard time with it, just think about, these are really disingenuous arguments that are actually underlying, and when you take them apart, presume that people who are living in poverty is because of their own personal failure, right? That's what people are really saying, that these folks are any different than any of us who might not be living in poverty. And we know that's not true. They're all humans. They have the same human drives. They have the same basic drives. It's not a matter of laziness. There are lazy people across all the spectrum. Don't I know? I've been to a lot of places and found them everywhere across all different spectra. That's not what this is about. This is really about preserving people's human dignity and right to live. So we take those out. So also want to emphasize again that this is considered an equity approach because it's needs-based. So if you think about the difference, and this is a graphic from the Robert Wood Johnson Foundation, between equality and equity, right? Equality would be giving everybody the same thing, right? That's the basic income approach. Give everybody the supplement. Give it to everybody. But the challenge is that actually that's not necessarily tailored to what people need, because some people actually don't really need it and won't benefit from it as much. So it's an equity approach by focusing on those who need it and offering them additional help so that they can get their lives pulled together. We also actually see this as this is actually an intervention that has for a long time been rooted in dismantling structural racism. So in the United States, the case for guaranteed income was actually made back actually in the 60s and 70s. So these are actually not new ideas or new programs. And this was a time when they were expanding the types of anti-poverty programs that were being offered through the government. However, there were certain categories that were being excluded. So, for example, single parents, single mothers, and people who were unemployed were being essentially blamed for their own poverty and were actually excluded from having access to the anti-poverty programs in the 60s and 70s. They even did some things, for example, Black Americans were often deemed unworthy of assistance and restricted from accessing benefits even when they were eligible. So several Black women activists got together and started championing and pushing for a guaranteed income. Something, again, that was unconditional, provided levels of support, and could be granted to everyone in need, not just the categories that people deemed morally acceptable. And the idea and the way that this links to health particularly is that we consider in social structural racism as a fundamental upstream cause, that you give people, that you have a guaranteed income program in place, and then that helps disrupt inequities in things like income, housing, education, employment, because people are able to meet their basic needs. And then that then leads to people either having better access to care or being able to directly avoid some challenges with mental health, physical health, the ability to access health care and handle unmet health needs. And again, in fact, this is not a new idea. This is something that we've been doing for quite a while. And in fact, back in the 1960s, Dr. Martin Luther King actually talked about this and said, the solution to poverty is to abolish it directly by a now widely discussed measure, the guaranteed income. Widely discussed. So this was really, really big back then. We don't, again, it's only really reemerging in conversation now, but it is something that we have done in society and that we can bring back at a larger scale again. All right, so because I'm a professor, there's always a quiz involved in this, and we're going to do this by show of hands. So this is based on the characteristics that I talked with you about in terms of what guaranteed income is or is not. So just quickly by a show of hands, I'm going to name some social safety net programs. You tell me whether or not you think they are guaranteed income programs. So the first one is Social Security retirement payments. Who would say that those are a form of guaranteed income? Anybody? Okay. Not too many people fell for that one. So nope, they're not guaranteed income programs because they're based on having a work history, right? In order to get the retirement benefits, that's work history. So these programs are not conditional on work. How about the Earned Income Tax Credit, EITC, supplement for lower income families? Also, their payments are based on work history. So again, it's another one that's conditional. How about the COVID stimulus payments? Is that a guaranteed income? Okay, more people there. Okay, a couple people there. So that one, it actually might be the closest to what we've seen contemporary in terms of what broad scale type of guaranteed income. It's a little bit closer to basic income because pretty much, well, I would say most people got it, but it also wasn't fully recurring. Remember, recurring was one of the categories, right? People got it, maybe 2 or 3 times. So in general, the guaranteed income programs are recurring monthly or quarterly or something like that over a much longer period of time, but kind of the similar idea. And the last one I'll ask about is, what about Social Security Disability Insurance, SSDI? Any thoughts about that? Okay, y'all are all coming right around to it. That one is another one that's based on work history, right? It's based on work history. So it's for workers who have become disabled after having contributed to the fund long enough to actually earn the benefits. All right. So now you're getting a sense of kind of, we do have these other programs, but they're not exactly or quite guaranteed income already. But as I said before, we've actually had various types of guaranteed income programs in our society before. So for example, in 1996, the Eastern Band of Cherokee Indians got a casino dividend. So this was an ongoing transfer, essentially a deal to be able to put a casino on these native lands. And then each person in the community there received some part of the dividends from the casino. And when they looked at the health outcomes there, they found that there were measurable improvements in the children's lives on the reservation, as well as outcomes and adult psychological health. In 2016, Dolly Parton also did one. They gave $1,000 a month for survivors of wildfires in Tennessee. That didn't look at health outcomes, but again, it starts setting a precedent for these types of programs and in fact being philanthropically funded. There's one that you might have heard about in the newspaper called Baby's First Years that just now has results coming out. So I'll talk about some of the other results with this study, but that one gave $333 a month to low-income mothers in New York City, New Orleans, Minneapolis, and Omaha, Nebraska, and then it is collecting information in an ongoing way about child health and development. The most popular one right now is the Stockton program. It's called SEED, Stockton Economic Empowerment Demonstration. That gave 125 randomly selected residents of Stockton, California, $500 a month for 24 months. And so far, those results are still rolling out, but after the first year, they were already starting to see improvements in emotional health. And then there's the Magnolia Mothers Trust. That's $1,000 a month per year. I believe that's the only one that goes to pregnant persons. So that goes to Black mothers living in poverty in Jackson, Mississippi, and they collect data on health and family well-being. Results still coming out. So there is one other that's not listed on here. Is anybody here from Alaska? Spent some time in Alaska? No? Nobody? No Alaskan? Maybe there's some folks online from Alaska. But Alaska has had a guaranteed income program since 1982, the Alaska Dividend Fund. And this grants money to Alaskan residents based on gas and oil revenues through a fund. So this actually happened in response, there was a response to a drop in wealth in Alaska, and so they did this as an economic intervention for Alaskans. I think that a lot of people hear, like, oh, you go to Alaska and you get this money, what is this from? That's what that's from. So again, we have lots of precedent for doing this for different populations in the United States, and we can think about expanding it to other populations. And in fact, that's already starting to happen. So there's a program called Mayors for a Guaranteed Income with mayors across the nation. There's over 100 mayors across the nation. I think there's even more than when I printed this slide out that have been doing these programs and rolling out these programs all across the nation. And I was really working at the pleasure of the mayor in Baltimore as part of the Guaranteed Income Steering Committee to help launch Baltimore's Guaranteed Income Program. And I'll talk more about that and some of the things that we learned about health from that program. So as we talk about the potential impacts on health, there are some things we already know. So for example, in that Stockton pilot that I mentioned, that seed pilot, what they found at the 1-year mark was that they saw clinically statistic improvements in emotional health, energy and fatigue, emotional well-being. People did reduce their work hours, but when they talked to them, they found out it was for self-care, for family care. Again, it was that kind of going from 3 jobs to 2 jobs, doing education or new pursuits. They were able to better afford healthcare over emergencies and copays, especially in cases where Medicaid actually didn't cover the cost of a health expense that they needed, filled that in. And then they also talked about having improved and safer housing, secure housing, and home repairs. And this was one where, again, they gave $500 a month for 24 months. This one, I believe the data collection on this just finished in the last 6 months to a year. And so some of the results of this were still pending in terms of what some of the longer term health impacts. But that was after just 1 year of the program. There's also another one, the Baby's First Year one that I mentioned before. This was the one that they were actually giving money to mothers and then following child development outcomes. And this one was really interesting. They actually started seeing that within the first 6 months of child development, the families that had received the guaranteed income already started seeing better and more healthy rates of child brain development within the first 6 months of birth. So, it changed the way that they showed stronger cognitive development. And I would say there were some modest associations there, right? This wasn't very strong associations. But the idea is that there might be, and they'll continue to follow these children as they grow over time to see what potential longer-term impacts there might be. So kind of having those two projects, most contemporary projects, we embarked on a series of projects to better understand what might be these links between guaranteed income and health. What are the mechanisms? How does this work? And what can we know so far from what's happening all across the nation? So the first thing that my team did, and this was a combination of doctoral students, Holly Nishimura, Sylvie Snoon, and Dr. Marique Moen at the University of Maryland, we did a project actually pre-implementation to Baltimore's program. We did a literature review. We talked with community partners who had received some sort of, I would say, similar to guaranteed income payments during COVID, and we talked with community leaders. And then we developed a framework to try to better show how is guaranteed income linked to health, how does this work? So our team is there. And the first thing that we started out with was what's already existing in the literature? What do we know about these programs already and their links to health? So we did a scoping review to just think about, and a scoping review is a systematic type of review, but the goal of a scoping review, differently from some of the other reviews, is to literally understand what it sounds like, the scope of the literature. What health outcomes have been looked at? What haven't been looked at? What are the gaps? What do we know? What don't we know? So we looked for guaranteed income initiatives, and I should say these were focused in North America. We're currently doing one that's global, but that is a lot more studies, so it just takes a lot more time to do. And we're looking at physical, mental, environmental outcomes, as well as healthcare quality and access. For this one, we didn't look specifically at social determinants of health because we felt like that would just be so many, it just would be infeasible to get through those data. So we really looked at, as much as we can, strictly at health outcomes and healthcare usage. So we used a couple of databases and did some hand searches, guaranteed income, cash transfer, and income support, and used a software called Covidence to screen those articles. We looked at a number of databases as well as a couple of places that we knew that that data were available, and then we used health as an outcome in the string search. So what we found, in total we found 28 studies published between 1976 and 2022. 27 of them were quantitative and one was qualitative. And they focused on outcomes including cardiometabolic disease, nutrition, mental and behavioral health, maternal child health, and healthcare utilization. At least those were the most common that we saw. And in fact, the most common out of all of these was maternal and child health. So that seems to be where we have the most robust data to understand the impacts of guaranteed income and health. We found 13 unique programs. There were 16 though across US and Canada. So we said 13 unique programs because some programs had kind of stopped and restarted, those sorts of things. So 13 total unique programs, but 16 programs overall. The first one was the Mother's Pension Program that started in 1991. And the most recent one was the Baby's First Years one, at least at the time that we were doing the review. Some target populations included focusing on mothers and children, and the amounts of money that we saw people receiving were, and again, this was North America, well, we did US and Canada, 81 Canadian dollars to $4,000. And the numbers are a bit misleading because in some cases they were reporting how much they received per month, and then sometimes they were reporting how much they received total. But the frequency tended to be something like semi-monthly, annually, but most of them were monthly. In terms of the scoping review results, we found a couple of things. In terms of maternal and child health, we saw positive outcomes. We saw increased fertility outcomes, breastfeeding, childhood vaccinations. We saw lower preterm birth, lower low birth weight, lower malnutrition and developmental delays. For physical health, there were some mixed reviews. Some studies reported kind of healthier weights and BMI, some studies didn't. Though nutrition is a large outcome that we see people looking at in these studies. Lower disability among adults, increased healthcare utilization, though we saw increased emergency department admissions, which I think was a bit of a surprise. I think we expected for people to be moving out of emergency care to other forms of care. At the same time, it's very, very tricky in terms of health services research to understand what that actually means. That could mean that people weren't getting care at all, and now are at least going to emergency care. So we're not exactly sure how exactly that works or what that mechanism is. But we also saw decreased hospital admissions for things like infections and injury and lower Medicaid spending. And we're presuming that that's because people with the additional income were able to offset some of those other health outcomes. And then in terms of behavioral health, especially for children, lower aggression, hyperactivity, and for adults, lower substance use disorder and emotional disorders. So overall, what we found in this scoping study was GI had a positive effect on health outcomes, and that the greatest gains were observed in the lowest income individuals and in families. Some of the things that this couldn't tell us, though, and some of the questions that we still have is, how much money is enough? How much money is helpful? How long do we need to have these programs in place? Those are questions that are still unanswered and that we're still working to understand in some other parts, and I'll talk a little bit about some of the other work that we're doing. So we have our scoping review that's currently under review at a journal, and hopefully you'll be able to take a look at some of the full set of those outcomes soon. So as I mentioned, we also did some pre-program qualitative interviews, and I'll just go over this quickly because we did some post-program qualitative interviews that I think are even more informative, but I just wanted to touch on this. So we did some semi-structured interviews with Baltimore City community partners and residents, and we essentially did an analysis to understand what they thought a guaranteed income would do. Again, these are pre-programmed to Baltimore. So some of the things is that some people knew that this program was coming. Some of them had received cash transfers for COVID, but most people actually did not know about this program or know the details of the program. People mentioned that they felt like certain populations should be prioritized, so low-income individuals, mothers, or young people. They felt an amount of $500 to $2,000 per month would be enough, at least in Baltimore. But that could be adjusted based on people's household size, that the program should last at least a year, and that there were some other considerations. For example, some people were concerned about, well, if someone has substance use disorder, will they go out and use these funds, and will they actually be at a greater risk for substance use related outcomes? As a side note, I don't talk about this in this particular presentation a lot, but that is also not borne out in the literature. That guaranteed income does not exacerbate people's substance use disorders. When people get this money, they are spending it largely on rent and basic needs. They are not spending it to increase drug use. We just have not seen that. In terms of in-depth interviews, we did some of the major themes they talked about was they felt like it might work on health through a pathway of more nutritious foods, or people having their basic needs met and having decreased stress, which might improve their mental health outcomes. They also talked about time being an important social determinant of health. And Gil G, who's now at UCLA, has a great paper on time as a social determinant of health and why time preservation is so important, and why time is stretched, especially for people who are living in poverty situations, because they actually have less time because of the systems that they have to navigate in order to get their basic needs met. And that takes away time from the other things they need to do to be healthy. They talked about improved, obviously I think everyone believes it'll improve financial stability because you're getting more money, but then that could also improve your outlook, your generosity, and actually the resources that are further available to people in your community, so community cohesion. So overall, what we came up with is this framework that essentially looked at guaranteed income in North America being associated with social determinants of health. And you'll see these dots, some of them are gold, some of them are blue. The gold dots represent things that we heard about in our interviews that are not in the research literature, at least not yet. The blue ones are the ones that were in the research literature, and anything with both dots appeared both in the interviews as well as in the literature. And there's also a time clock that you might see. Those represent things that people saw as long-term outcomes, so things that might happen even after people stop getting the money. So social determinants of health included, financial stability, better housing, having more time, and even there was some evidence around young people ending up having more years in school and less justice system involvement. In terms of psychosocial health, across the board, people talk about stress reduction. We also see that in the literature, as well as fewer mental health care diagnoses. For adult physical and behavioral health, food security, we talked about healthy weight and physical function having some mixed findings, but other interesting things like less pain, less drug and alcohol use, longer life, and less chronic diseases popping up over time. For maternal and child health, overwhelmingly positive, better maternal health, infant brain development, vaccinations, fewer behavioral disorders for youth, and access to and use of care include things like medications and medical visits being able to be covered, more use of health care, and insurance coverage being stabilized. People also felt like it had spillover effects into the environment. So, for example, the ability to make repairs on things like your car or your house, or find better housing that's safer, and possible improvements in things like social cohesion and lower violence and crime rates have been supported by the literature. So we developed this framework based on the scoping review and based on our interviews, and then move forward with thinking about how this works mechanistically. And I won't go through this slide because there's a lot that's happening on this slide, but I will say that at the end I'll share that this slide is part of a toolkit that we've developed for people who want to understand more about how to evaluate guaranteed income or health in the context of guaranteed income. So that toolkit is available on our consortium website, and I'll share that at the end so people can look at this a little bit more. But I would say at the time we were doing all this, what happens? Mayor Scott announces the Baltimore's program launch. We're very excited about this, and we start working with the mayor's office to ensure that Baltimore's guaranteed income pilot becomes the first one that's focused pretty much exclusively on the health of adults and children. So the Baltimore program is called the Baltimore Young Family Success Fund. It's 200 participants. They get $1,000 a month for 2 years. And again, all of the things that I said before, recurring, unconditional, unrestricted. And we developed a project to better understand how does this work in terms of structural racism and how does this work in terms of impacts on health. So 3 of us got together, that's me, I think you can probably tell. Stacia West, she was the one she works for University of Tennessee, and she runs the Center for Guaranteed Income Research Program. She was the one who led the Stockton program. So it was great to have someone who kind of a contemporary champion of this. and Dr. Scott Nolan, he was a community partner. We did this under the Robert Wood Johnson Interdisciplinary Research Scholars Program, which partners researchers and community partners to do projects of these types. And we had a pretty expansive team of doctoral students, graduate students, outside community research assistants who were working together to try to understand a couple of questions. So the first one, how can a guaranteed income as a structural racism intervention impact health or the social determinants of health? Does it impact mental and physical health? Do we see differences by race and gender? Do we see differences in access to health care or health services? And then how are the social determinants of health impacted? And how do these impacts differ by race and gender? All right, I'm gonna set some expectations. You are not gonna know the answer to these questions by the end of this presentation because this work is still ongoing. We actually are still working on these analyses, but I'll at least share with you what we know so far and give you a preview of what's to come on this. So we did this as a mixed methods project. The first started with some more qualitative interviews, but these qualitative interviews were of people who were actually in the guaranteed income program while it was happening. So we did a series of interviews with them. We did a photo elicitation project, and we'll talk a little bit more about what photo elicitation is. And we did that with a couple of people, and what we want to do with the photo elicitation project is actually create a policy lookbook so that policymakers can literally visualize how this is impacting people's health and lives. And then we did, there's a health survey that happened across all of the, well, I should say, there was a survey that happened across all of those mayor's initiatives that I talked about, a standardized survey. So we pulled out the health questions that were already being asked in that survey and are working on a meta-analysis of those. So let's just start with the interviews. In terms of the interviews, we interviewed 23 of the participants in Baltimore's program. Baltimore's program was focused on young adults, so you'll see that age range of 21 to 26, because that was the age, they had to be under 26 years old. The vast majority of them were black. One was just some other race. Also vast were not Hispanic or Latine. Two identified as Latine, and they said they were Cuban. We had most people were either in that high school, college, or some college, or had some sort of technical degree. In terms of employment, most people, well, almost everyone was employed except for 6 folks. The household side ranges anywhere from 1 to 5 people. And the other requirement of the Baltimore's program wasn't on that original slide, is that these all had to be parents. So they had to have at least one child in the home. So this was really focused on young adult parents who were trying to get their lives started. Most people did have some insurance. Their primary insurance tended to be around Medicare or Medicaid, and most children did have, this is child insured in the past 12 months. That should be switched around. I think most children actually did have insurance, and then the primary insurance for the children was usually some sort of state Medicaid program that was available. So the interview themes, what we learned from the interviews in terms of how guaranteed impacted people's health is that a lot of people talked about how it influenced transportation, employment, mental health, caretaking, housing as a social determinant of health, healthcare, diet and nutrition, community health, and physical health. And I'll share just a couple of the quotes that we have for this from each of these, for some of these themes. So for example, in terms of mental health, people talked about that they were less stressed with the guaranteed income program. So for example, one participant said, I definitely gained about 50% more confident and less stress since I came across the program. Another one talked about finally being able to talk with a therapist twice a week or as much as they needed. So actually getting direct care for their mental health. And some people even talked about sleep outcomes. They said, I don't have to keep thinking that they have to pay something because now I can actually afford to pay it. So people able to both take care of their mental health, get mental health care, as well as prevent future mental health challenges by being able to get some of their basic physical needs like sleep met. In terms of health care, people talked about being able to pay for their medicine or medical bills. They said, I'm able to pay for medicine that I wasn't able to pay for, not just for my children, but also for myself. And I also want to just pull out the juxtaposition. It's so interesting that they said not only for my children, but also for myself, which also was a clue to us that people are really prioritizing their children with these payments. The first thing that they think about is taking care of the needs of their children, not for themselves. So as we think about especially giving these monies to families, I really do think that we need to fully explore what the impacts on children are, because I do think that at least what we're seeing in the Baltimore pilot is that people by and large are using this to stabilize their children's lives. In terms of healthcare coverage, one person talked about there was a special type of medicine that their son needed when they broke their arm. They didn't have money for it, and then they were able to pay so not only a little bit of the bills, but also the medicine that he needed in an ongoing way. And they also talked about having high blood pressure, so they were able to pay for that, and that's something that they needed to do until their insurance plan stepped in. So, right, we also see this as being something to fill in the gaps as other programs are not serving people, right? That's what this income is able to do. And again, another one, they talk about, they prioritize their children's health first before they even talk about their own. Which leads us to caretaking. Caretaking was another theme that we saw. They talked about being able to better take care of their family. They talked about, for example, someone said, I feel like what's needed to be done, I can do what I can to properly care for this child, and the basic income basically gave me a sense of security that I'd be able to take care of this child. And they also talked about things like transportation, being able to pay for bus passes, car notes, getting their own cars, ride sharing. Someone talked about I was able to buy monthly bus passes for myself. So even if I didn't have the money to buy a bus pass, I didn't have to worry about that because it was already a 31-day bus pass ready for me whenever I needed it. So they were able to kind of get something up front that they knew that was going to last them till the end of the month. So we saw these in the qualitative interviews, but we also saw these represented in the Photo Voice project. So we did a Photo Voice project, and the idea behind Photo Voice is to actually equip people. Well, I would say there's two different ways that it could be done, but it's the overall idea of using pictures as a research tool and eliciting what you can both from the pictures themselves as well as qualitative interviews that accompany the pictures that people are taking. So for the Photo Voice, in this case, we did a true Photo Voice, which is where the participants took the pictures themselves. The participants are taking the pictures themselves, and then they wrote a narrative about what the photo means to them. So this is us. This is Bree. She was doing our training. This is one of the Photo Voice sessions that we had, and we would train them how to both use cameras. We gave them the cameras as part of the incentive, so it's nice they could take the camera. They also talked about using those cameras as part of artistic ventures that they wanted to do. But part of their goal was to take these cameras and then use photos to answer the question, how has participation in this program impacted your life and health? And we used an evidence-based method called the SHOWed method to talk with them about each of the pictures that they took. So essentially you ask, what is shown here? What's really happening? How does it relate to our lives? Why are things this way? How can we educate people? And what should be done about what we see in the picture? This has been a particular method that's been used around food insecurity. And someone named Mariana Chilton has used this very successfully with policymakers around showing them the impacts of food insecurity and helping to change food policies in the United States. So we're hoping to do the same thing with guaranteed income. So this is one of the photos that we got that the participant called "Guaranteed Income Helped Me Get My First Place." She said it helped me maintain at least my first place. Before this, I lived with my foster mom, but now I live in this place that it's walkable and it's in a cool neighborhood. It's not too far from my mom and everything. So we saw people literally being able to move out of housing instability and personal homelessness to be able to having their own places and maintaining with it. We also saw people being able to move into places that were healthier. So for example, another participant said, our house was full of mold. So when we got the GI payments, we moved into a townhome that was smaller, but safer and cleaner. So they were able to move away from the housing challenges. But I'd also say that even with $1,000 a month, people did not talk about this as if, they were not moving into, mansions or anything like that. In fact, one person said, I still live in the hood. It's just a different hood. So I was able to kind of get incrementally better than I was, but this is definitely not enough money to be living this large life that people think it is, right? I'm still working my way up. Another one talked about, this is a picture she called Eskimo Kisses. And she said, she described that her son pictured here has autism spectrum disorder. And that in the past, she actually couldn't physically touch him. He just wasn't in a place where he could do that. But she said she actually now can do Eskimo kisses with him. And she talked about having the time and resources to network and learn from other families families dealing with autism spectrum disorder. And she was able to get resources for her son that enabled him to get better treatment for his autism. And you saw his developmental changes over time and their relationship and their bond improve, which is another thing that we saw. We heard a lot about parent-child bonding improving and getting better as a result of the guaranteed income, as a result of having the time and resources to better care for their children. And in fact, I think this is another great example. This one was called the 1-year birthday. She said, this baby was born in the struggle. We were homeless, and then we were able to move into a 5-bedroom house. And he has lived a great first 15 months. And she was able to have this birthday party for him to celebrate his life in their new home. So again, similar themes of being able to better take care of children. They also talked about what's going to happen as these programs end. So one participant had started doing hair before guaranteed income, and then throughout the guaranteed income, she was actually able to start really setting up her hair as a business. She said she now was able to create a budget. She would have loved to create a budget before, but she didn't have any money to budget. So this enabled her to actually have funds that she could use to set herself up for her future, and now she's going to be formalizing her hair business as an LLC, a limited liability corporation. So she said, it helped me think about what I should be spending on, for example, with things like limiting fast food. But now that I'm recognizing that this program is going away, it's also helping me to think about what I need to do in the future to be able to feed my family. So she said, let me go and get this degree. And I think in this case, she was talking about a nursing degree that she's moving into after the end of this program. So again, you can really see, as I talked about before, this is really a hand up for families, right? They're not able to, move into these other places. It's not something that's exploitative. It's not so much money that people are able to, they're able to radically change their lives in some ways, but set themselves up for the future. But there's also not a sense of that people are exploiting a system either, right? They're using this money in helpful ways. All right, just a couple of more things before I wrap up. So in addition to the qualitative work, and I am actually mostly a quantitative researcher, but the qualitative work was the results that we had the most easy access to for the purposes of this presentation. We are working on a larger meta-analysis based on the survey data from the other pilots that have happened all across the nation. So we're doing an individual participant pool data analysis of the other studies out of the Center for Guaranteed Income Research that have happened or that have completed as of 2023. We're going to be looking at disparities in health and wellness at baseline 6 and 12 months across the 4 categories that all of the pilots have data on, which is physical and mental health, psychological well-being, perceived stress, and household food and insecurity. In terms of the programs that we've done, we are looking at programs all across the nation, but this is still a subset of those over 100 programs that I showed you. But these programs range at different geographies. The smallest pilots are in places like Santa Fe and Columbia, North Carolina, and the largest is in LA County. The range of amounts that people are receiving is anywhere from $350 to $1,000 a month, depending on the city. And the common populations that they're focusing on are disconnected young adults, fathers, recently incarcerated persons, and young parents. So hopefully this will be forthcoming and you'll be able to read those results soon. All that to say, some of the things that we already know now is that guaranteed income has the potential positive impacts on health and social determinants of health. But by all means, we understand that it cannot solve all health problems. It's a patch for the gaps in our existing safety net programs. So we still need the same safety net programs that we have going on right now. But this is something that we could add that we know that would additionally help with some health outcomes, but we understand that it's not expected to help all health outcomes. But what can? We'd love to be able to expand our network of people who are working on this. The vast majority of people who have been working in guaranteed income and health are economists. We love economists, but they're not health researchers necessarily. So if we want to better understand and explicate how this works on health, we do need health researchers. We've started a national consortium on guaranteed income and health, which anyone can join. We have meetings monthly where we have everything from trainees to faculty to community consultants as well involved in this group to really shape the national agenda on how we understand the health impacts of guaranteed income. We even have a toolkit that we're going to be releasing soon, and this is to help pilots. If there's a pilot here, if there's a pilot in other places, and they want to understand what should we do to incorporate health or to better understand health, we have some tools to help think about how to incorporate health evaluation into there. So thank you for your time, and I will take questions.
Thank you for your talk. Very illuminating. It was more of a sort of, did this income reduce their access to other services? Because I know that those are very small limits for Medicaid, and I was just wondering how that works within these programs more generally, if you know.
So that's a great question. That was a big consideration in how these programs are rolled out. So what most places have done is, so the short answer is no, it doesn't actually impact their eligibility for other programs. And it also doesn't have a tax liability for them either, right? Because that also kind of be somewhat regressive. What they did was they framed these as gifts, and then they got a waiver for the amount of taxable gift that a government entity can give someone. Because there are even laws about, right, how much people can receive as a gift. So they had to get a special waiver, often from at the state level, to be able to give these funds. But as far as I know, pretty much every guaranteed income pilot has been able to get those waivers so that there is no tax liability or impact on their programs. The other thing is, because this program is short, these programs are short term, right? They're only a year or 2 or 6 months. People were very careful to make sure that it didn't affect eligibility for long-term benefits. So thankfully, no.
Hi, thanks so much for your talk. The only reason I knew about GI was because there's an organization who's actually right down the road doing a GI program. At least a couple of years ago they were. I don't know if they still are. It was like a pilot, I believe. They're called PCCI. And so I was just wondering, with community organizations who are doing this kind of work, like where are they receiving funding from? And I know you had talked a lot about different, different mayors having these initiatives across the country. But in terms of doing it on a community level, like I'm just curious about how that typically works.
So yeah, these are honestly even health researchers. I was talking with Dan about this earlier. He was like, we don't get, our grants are not even large enough to do these programs. So these programs are generally funded by a combination of philanthropic dollars and federal dollars. So at least in Baltimore, for example, so the Mayors for a Guaranteed Income group, part of the reason that they join is because there's philanthropic donors behind those programs that are paying for part of the health evaluation as well as the disbursement. Then there's also local funders. So in our area, we had like the Annie E. Casey Foundation, other foundations, Urban Institute that came in and chipped in funds. So these are philanthropic nonprofits also chipping in. And then also, at least in Baltimore, we used ARPA dollars. The city had some, I guess, unused ARPA dollars from the federal government and then chipped in some of that to run the program. So I would say there's a number of funding sources. But I think the largest actually comes from philanthropic funds and donors. And that was also important because we didn't want people to be able to say, don't use my tax dollars to do this. And we say, good, we didn't use your tax dollars to do this, right? This was funded in completely different ways.
Thank you.
I was going to ask, the implementation of it in Baltimore,
There we go.
the implementation in Baltimore is only citywide, right? So having this on a state level or federal level, considering that you would have to do the thing with the gifts where you give them a state credit, would it differ on a federal or state level? Not necessarily just in scale, but like the implementation. Would it change if you scaled up?
So currently, for example, in Maryland, there are actually 3 pilots. There's Baltimore, there's one in Montgomery County and Prince George's County, and they're all separate. And most of the programs that exist now are in separate locations. California, as far as I know, is the only state that's actually trying to do a statewide program, but they are actually largely using what's happening at the local levels in terms of the implementation. So the belief is that the scale up is almost exactly the same as what's happening at these local levels, and in fact is sometimes harder at the local levels than it is when it's originating from the state levels, because the local levels have to then sometimes deal with state preemption laws or other things that at the state level they can just tackle head on in the legislation. So California is our model for how this is working, but has not happened yet. Mm-hmm. Yeah, go for it.
So you showed us a graph earlier that had like the different amounts that were being sent via different cities.
Mm-hmm.
That one, yeah.
Mm-hmm.
So with California, have they done it in such a way that it's like by county, they have a specific amount based on how much people make in that county, or would it be a statewide, everyone in the state makes or is given the same amount?
So I wish I could say that the amounts themselves were in any way evidence-based, but they are not. Um, again, most of these were mayor's initiatives, so there was some political impetus behind them, and a lot of the how much it is was how much money did we fundraise from philanthropy, and how many people do we want to be put in this? They were all randomized control trials. How much can we put in this randomized control trial? So I would say no, they were not adjusted for cost of living. But actually, in our meta-analysis, we're doing a cost of living calculation adjustment to see how much money actually, if we standardize this to a U.S. universal standard, how much were they actually getting, kind of as a universal standard as percent of the AMI in that area median income. Mm-hmm.
Afternoon. Thank you so much for this talk, Dr. Dean. So a couple of questions for you, and you started to mention it when you mentioned that these were RCTs.
Yes.
I was curious about the eligibility for the Baltimore program, and then also when you say guaranteed income has the characteristic of recurrent over a period of time, I also saw in your previous timeline that those different programs had a variety of different time spans.
Mm-hmm.
So I'm curious about what defines that recurrent period.
So the first question was about eligibility for Baltimore. So Baltimore, you had to be, I think it was 18 to 26, and have at least one child, or be the caretaker of a child. So it could have even been a niece or nephew. And you had to be within, I think they had went to 300% of the federal poverty line. But in actuality, when we actually look at the demographic participants, the median income of participants in the Baltimore pilot was $7,000 a year. People were very, very low resource. So even I think people were like, why is it 300%? I think they were trying to be a little bit generous there, but by and large, the people who received this just did not have a lot to begin with. And then the second question was the same answer as before. These were mayor's initiatives. How much money did they have to give? For how long did they have to give? So they were not research decisions or evidence-based decisions. They were resource-based decisions, or sometimes just political decisions, talking points. So it gave us some opportunity, but not completely research-driven at all.
Oh, thank you for a great presentation. A couple years ago, I actually did a TANF lever study,
Yes.
measuring women that had left welfare. We found median debt levels $7,500 per family. I would hypothesize that this guaranteed income would lower debt levels, and that's related to mental health as well. Are any of your studies measuring levels of debt?
We are not, and it's interesting you say this because my other body of research, I do credit scores, credit history in health, and so I really wanted to actually try to attach credit records so that we could look at things like debt in other forms of wealth. But no, they don't have any sort of those records on these folks. We're trying to do an additional study now where we link claims data, external claims data to these participants with a waiver of consent. So that might be something we can do in the future. I have not seen debt looked at. Oh, that's a good question. The economic studies that I have seen, if they have, I don't remember seeing what the particular findings would be. But remember that most of these studies have happened in the context of low and middle income countries. So they're, other than the ones that I talked about with that scoping review at the beginning that have been done, there just hasn't actually been a lot in this context. Yeah.
Last two very quick questions. So again, echoing everyone's thanks for both coming here and for this really important work that you're doing. One very granular question, which is, I noticed about half of the participants in your study were covered by Medicare. It's unusual for people in their 20s to be on Medicare unless they have a chronic disability. So if you could just talk about that. And then the other question is much more high level, because we have a number of students and students to be in the room. How did you get to this work? I mean, this isn't what you started doing, but we're very excited. I'm very excited this is what you're doing. How did you get there, and why did you choose to focus on this area?
So the Medicare question is also interesting to us. There are a couple of thoughts we have on this. One is we actually are not sure that people understood when we were asking the insurance questions, the difference between Medicare and Medicaid. And we think they just checked the first box when they saw Medi. So in that claims linkage analysis that we're trying to do, that's one thing that we're actually going to explicitly explore is were they actually on Medicare or were they on Medicaid and just didn't know what it was called? One is, yeah, I think maybe just I would say health insurance literacy question. The other thing is, right, they might be on other forms. I mean, maybe this is a population that does have a larger level of disability of some sort. We actually don't have metrics on what those disabilities would have been, so it is possible that they are correct. We just don't know yet, but we're going to be looking at that. How did I get into this work? So I would say two ways. One, prior to coming into academia, I ran Philadelphia's tobacco control program. So I've always been interested in how things, kind of policy level interventions impact people's health outcomes. And also in my social epi work, I focused a lot on economic challenges that people face. One of my doctoral students, who's from California, actually mentioned this to me and wanted to do guaranteed income as part of their dissertation. So really, the doctoral student brought me into this work. And we've been working on it ever since. In fact, the doctoral student co-leads the consortium. We'll be doing this for their postdoc as they move on and other things. So for me, it was just, I had to jump on this opportunity. I feel like in academia, we get so few opportunities to do, these kind of what I would call a life-changing intervention. I mean, there was no way I was going to miss out on using my skills and applying my skills here. Yeah.
I want to echo. Thank you for coming. We do have a reception, so I know there's probably a lot more questions that people would like to pose to our speakers. So grab some snacks, bring your questions, and meet us out there.
Thanks for coming. Uh-oh. These people want to reach out. Yeah, sure. Should I do that or go back?